really, what kind of focused on today is we're going to really kind of try and hit some of the high points or the characteristics of folks who have been exposed by prenatal alcohol. And talk about the characteristics and how they might contribute to suicide risk for somebody. And then the other piece is that we're going to try and get to is hopefully by the end you'll be able to identify and discuss what might some of this mean for working with folks in terms of mental health, but in terms of suicide assessments. I know there's some folks who who work in agencies and mental health related agencies, and I'm guessing there's probably some folks who are probably caregivers sometimes. Quick show of hands, here in Anchorage, how many people are caregivers or family members of someone who's exposed? Okay, good. This will probably be a little more focused on some of the some of the clinicians, but as we go, feel free to ask questions and raise your hand. Anybody, actually, I'm real comfortable being asked questions, because I find that if you don't ask them, people tend to forget them, and so okay. Oops. Interesting. Some slides are out of order, according to here. I'm going to keep talking about fetal alcohol syndrome, and I'm assuming that everybody, because you showed up here, you have some brief awareness of it. But just real quick, fetal alcohol spectrum disorders is kind of that umbrella term that we're using to talk about or describe kind of this range or this cluster of consequences related to drinking during pregnancy: the physical, the mental consequences, the neurodevelopmental consequences that only occur as a result of drinking during pregnancy. There's a lot of other causes that can lead to those kinds of difficulties, but here we're kind of talking about the whole package, really, and we're talking about how they all kind of fit together. Okay, so this should be slide number 4. Okay, should be FAS Epidemiology. These are some current numbers that are out there related to FAS and FASD. In the United States, the prevalence kind of ranges from 0.2 to 1.5 cases per 1,000 births, which translates to about 1,000, or a range again, kind of 1,000 to 6,000 infants a year who might actually have fetal alcohol syndrome. Alaska has the highest documented rate in the United States. That's been put out there, and it came out of a 5-state epidemiology surveillance kind of project. And that rate for the overall fetal alcohol syndrome disorder was about 1.5 per 1,000. The FASDs, so the spectrum, not the specific diagnosis of fetal alcohol syndrome, because you have to meet some really specific criteria to get that diagnosis, which we could probably spend another couple hours talking about for another time maybe. But when we start to get into the other parts of the spectrum, the prevalence goes up to kind of 9 to 10 cases per 1,000, which kind of translates into about 40,000 people a year, infants a year born with being at risk for consequences of prenatal alcohol exposure, which kind of translates in Alaska to 15.4 out of every 1,000. When we're talking about prevalence, you'll hear this per 1,000. It's a population statistic, so we can compare across different areas. Alaska has about 10,000 births a year. Kind of a fairly steady number. Yeah. Now, that's just the general birth rate in Alaska. Yeah. Thanks, Marilyn. When we're talking about FAS and the prevalence and stuff, The numbers are really going to range depending on what specific population you look at. We looked at just everybody in Anchorage, that might get one number versus statewide, versus disadvantaged groups or different ethnic groups and so on. In foster care, they've done some research at the University of Washington. It's answered about 15 per thousand children and so on. In the juvenile justice system, about 200 out of every 1,000 folks have had some sort of alcohol exposure. So you're kind of getting the picture. Worldwide, we're starting to look at Russia and some of the orphanages in Russia, and again, they're finding kind of fairly high, 15 per thousand. Rural South Africa has some of the highest numbers right now, kind of the 41 to 46 per thousand. They're currently doing some work in Italy and in France that's starting to show some also equally high numbers, which they're alcohol cultures, big cultures. So it kind of gives you an idea of some of what the prevalence is. Sure. Where it says FAS, it's FAS. Yeah. Good question. And which brings up a good point is you kind of say FAS, and many times that means kind of like the whole spectrum. And I will try and be pretty specific. Where it's FAS, I'll say FAS, and the spectrum I'll try and do. So when we're looking at FAS, there are some challenges. These are all numbers that S2, which means that they are all likely higher because of the challenges of identifying drinking during pregnancy. I mean, just within our community, if someone doesn't ask about drinking prenatally, it may not get documented. Okay, so that should have been slide 5. And so now we're on slide 6. And this is just giving you a little picture of what suicide and suicide attempt rates are in Alaska specifically. This comes from the state of Alaska Division of Behavioral Health's Alaska Scorecard, which is looking at a number of kind of mental health related indicators in Alaska. And you can find this on the state website, or I can get it to you. But in terms of suicide rates, between 2001 and 2005, this is the age-adjusted rate, is at about 19.6 per 100,000 people actually complete suicide in Alaska. Again, they're age-adjusted, so they've done some statistical math to kind of compare against national numbers. In Alaska, we're at 19.6 per 100,000. The national data is about 10.9, almost 11 per 100,000. Now that's completed suicides. When you go down and look at suicide attempts that were significant enough to lead to hospitalization, the numbers jump up even more significantly. In the U.S., that's about 54 per 100,000, or in Alaska, it's twice the national, almost at 104. So this kind of gives you the picture. Now, what we're kind of dealing with. So what's the overlap between FASD, the fetal alcohol spectrum disorders, and suicide? And a colleague of mine said, in some ways, it's kind of like the needle in a haystack, because both of these, while these numbers seem very high for both fetal alcohol syndrome and the fetal alcohol spectrum disorders and suicide, they're very prevalence things that happen. So in the grand scale of things, they're not happening just always every day. So they're not happening tons of times. And so trying to find where the overlap becomes kind of a challenge sometimes. And because there's kind of a low occurrence rate for both of them. I think the other thing that kind of comes into it is when we're starting to look at this and we're starting to look at the prevalence numbers related to fetal alcohol syndrome and fetal alcohol spectrum disorders and suicide is there's been a lot of work done on suicide, and one of the things that they talk about is, they found that 95% of suicide victims have a psychiatric disorder at the time of death. Okay, that kind of fits with kind of probably what we think about suicide is you have a mental health issue that leads to suicide. But most psychiatric patients don't commit suicide, and which is kind of highlights it's actually a low base rate. It doesn't happen quite as often. A previous suicide attempt is one of the best predictors of a future suicide attempt or suicide, but only 20 to 30% of those who commit suicide have made a previous suicide attempt. So again, it's kind of providing a little bit of the groundwork here. So the overlap. Basically, kind of what I'm going to be putting forward is that, in talking about, is that folks with fetal alcohol spectrum, they have a number of neurodevelopmental deficits, a number of problems with their brain that are all impacted, that all impact problem solving, decision making, our judgment. Impaired judgment, our insight, our impulsivity, our impulse control, our executive functioning. And we can talk a little bit about that here in just a second. So the folks have these deficits and problems in the brain that contribute to psychosocial problems, social problems, and mental health problems at every developmental stage. As somebody's growing up and aging. And amongst those, suicide is probably one of the most significant and severe problems. Okay. So what is a primary neurodevelopmental disability? If you've read a little bit or heard about fetal alcohol syndrome and fetal alcohol spectrum disorders, you might have heard the term primary disability or secondary disability. And the neurodevelopmental disabilities, these are the primary disabilities. These are the things that are as a direct result of the brain damage that happens with drinking during pregnancy. So you've got a range of possible areas of functioning. Learning and memory problems, visual spatial impairment. And on this list, just because it's here, it doesn't mean that someone who has prenatal alcohol exposure has every single one of these. And likewise, if you have or fetal alcohol effect. I was teasing Sarah and Alex earlier. He was like, I actually thought this started at 6, up until about mid-morning, and at least I thought it was 6 to 8. And it's like, oops. That was kind of some of my memory problems there, and so anyway, so you've got learning and memory problems, visual spatial impairments, language and communication problems, executive functioning problems, and in parentheses, so I've got planning, sequencing, organizing, abstract thinking. Has everybody heard of executive functioning before? I see some nods through most of the Anchorage crew. And this is a real key one, actually, that you should keep in mind, and that I will probably come back to again and again. This is our brain's ability to make sense of the world around us. This is the part of the brain that does our planning and our sequencing, that helps us make good decisions in many ways. Cognition, that's kind of another area. Attention and concentration, motor control problems, fine motor, gross motor, coordination and balance. Excuse me. Sensory integration issues is another one. Have folks heard of sensory integration problems? Is there anybody who hasn't heard of sensory integration? Okay. Sensory integration is this is kind of the ability of our brain to make sense out of all of our senses. And and how those interact with our motor abilities. Okay. How many senses do we have? Okay, I see 5. I hear 6. Depending on your theories, I'm going to stick with 5 right now. The 6th one is probably up for debate. So what are they? And let's go through the first 5, and then we'll talk about 6. The sight, hearing, taste, touch, smell. So 5 different senses. So sensory integration, that's our brain trying to make sense of all of these different functioning areas. Okay? So like right now, here in this room, you're having to deal with all 5 of these, and each in your settings in Fairbanks and in Bethel. It's like, what are you hearing besides me kind of going in and out of the microphone and kind of my monotone kind of voice? What else can you hear in this environment besides the clicking of someone's pen, the rustling of the paper? You can hear shoes moving on the floor, clicking back there, maybe the projector, the fan. So you got this kind of hearing going on. What can you see? I mean, how does your environment around you look? Is it busy? Is it a lot going on? Is it plain? Is it too bright? Too dark? Okay, so we've got the hearing, we've got the sight. So how about touch? What are you feeling right now? Can you feel? How's the temperature in the room? Is it too hot or too cold? Is it just right? Okay, that's an option. How do your clothes feel right now? Are they scratchy? Are you wearing your comfortable clothes? It's like I see in Anchorage, I'm seeing head shake. No, not really. I mean, is it soft and fuzzy? Is it scratchy? Is it hard? Did it get your shirts get sparched? What other kinds of kinds of things? Is your neighbor touching you right now? Hopefully. But personal boundaries. No touching your neighbors right now. So we've got touch to deal with. Okay, so another type of touch that I don't think we realize is texture in our mouths. You know, it's like I see some folks chewing gum. What kind of texture? And now I see people smiling because I just called them out on chewing gum. I mean, what's that feel like in your mouth? Can you feel the gum? Is it squishy gum? Is it dry gum? Is it sticky gum? You know, whatever the qualities of your gumness are. And what's it taste like? Another area is, you know, until I came right before I got up here, I was chewing like this killer nuclear spearmint gum that, you know, it's like, wow. And I can still feel that even though I got rid of it. You know, what are you tasting right now? Are you tasting your dinner? Did someone have too much garlic? So you've got all these kinds of sensation that's going on. Then you've kind of got this other thing that you're trying to coordinate all of those, but then you're also trying to figure out where your body is in the world around you. It's called proprioception. Okay? And then maybe you're trying to move and coordinate your fingers and write notes and so on. So we're trying to integrate all of these and make sense that we can pay attention and so on. Well, sometimes with some of the brain damage that comes from prenatal alcohol exposure, sometimes folks get really overstimulated. Sometimes they're really understimulated. That's one of the challenging things about prenatal alcohol exposure is you can't exactly predict how that amount of alcohol is going to, sorry about that, cause some sort of damage in there. But yet it's something that we have to deal with. And then we've kind of got another area here that says emotional dysmaturity. Someone may be acting or functioning developmentally younger. Now, this isn't being immature. Immature is kind of similar, but at a certain point with the immature, you kind of work through the immaturity, and the dysmaturity is it's almost a little bit more of a chronic state where it's not necessarily going to change easily. So these are all primary areas, these brain-based things that can contribute to other problems, which we call the secondary disabilities. And on the slide, I'm now on slide 10, is the, I called, there's a number of different theories on what a secondary disability is, or opinions rather. I just kind of picked the queen of FAS, Anne Streissguth's work, and she's the one who's kind of got this known. And these are all areas that in a huge study that they did, longitudinal study, where they followed over the course of 30 years about 415 people, 430 people who had been diagnosed with fetal alcohol syndrome. And kind of over the course of this time, they checked in with the folks, and these were all problems that they were experiencing. Roughly 60% had some disrupted school experience, failing in school problems. 80% had problems with employment, dependent living. 80% were some environment to be successful. 30% or so in that area had alcohol or other drug problems. There's been some research that kind of separate from this that's showing that that prenatal alcohol exposure may end up leaving some folks a little more susceptible to later on alcohol and other drug use, separate from the just making poor choices. 50% or so had experienced some sort of confinement. So they'd been arrested, they'd been in jail, or they'd been confined in a state hospital or in a psychiatric unit, kind of thing. 90%, here's the big one, 90% had some sort of mental health problem reported. Could have been a variety of diagnoses. It could have been an attention deficit hyperactivity disorder. Could have been oppositional defiant disorder, depression, schizophrenia, personality disorder. But they were experiencing some sort of significant consequence related to mental health. Another piece of that was about 72% were the victim of some sort of emotional or domestic violence. A very high rate. When you start to look at these neurodevelopment, the brain deficits, the brain-based problems I was just talking about just a little bit ago, ends up leading folks to have a variety of experiences that make them at greater risk for being exploited or harmed and so on. Of this group of 72%, 50% of those had some sort of inappropriate sexual behavior. Now, this isn't being a sex offender, but this could be making some poor choices. For a while, when I was running the clinic, it never failed. It seemed like about a month into the school year, I'd get a call from a teacher, and usually it was a third grade teacher. For some reason, I have some theories about that, but it's not the teachers, so don't do that. It has to do with the difficulty of curriculum. It really significantly changes between the second and third grade. But anyway, the teacher would call and say, "I've got a student. I'll call him Mike. He's masturbating in class. What do I do?" It's like, "Well, what have you done?" And it's like, "I don't know." And it's like, I yelled at him. And it's like, "Well, did you ask him to stop?" Kind of, So they would. It's like they would be exposed to this behavior. Masturbation is a very developmentally appropriate behavior in terms of sexuality development and things like that. But what's not the appropriate thing? That's right. Don't do it in class. It's the place. Well, so then we end up problem solving with the teacher some ways to maybe shape the behavior a little more appropriately and help take it out of the classroom somewhere else. But, so these are all problems that people come into counseling for, in mental health services for. These are all problems that, for the folks who are in the helping profession, that come to you for assistance. You'll see these different things. So we're talking about mental health. Suicide was one of those big things. So talking about the risk among individuals with FAS. When we're talking about suicide, if you look at the literature and you go to the trainings, they always talk about suicide risk factors. And what are the suicide risk factors? And depending on who you talk to, there's 25 or 30, or there's 10, and so on. And a colleague of mine at the University of Washington, who's actually kind of worked with that group that we were just talking about, and Streissguth, they actually decided, okay, well, let's pick a set of suicide risk factors and see how that fits. And so they picked because they thought it would probably be a good representative, they picked the U.S. Surgeon General's risk factors of suicide. And they had 16 risk factors, and they looked at the risk factors and compared them against the symptoms or the characteristics of individuals. So the U.S. Surgeon General's risk factors, there's 16. When they looked at the characteristics of individuals with fetal alcohol spectrum disorders, they found that half of them easily met the risk factors of suicide. Mental health disorders, substance abuse disorders, impulsivity or aggressive tendencies, history of trauma or abuse. Are these kind of sounding like a lot of the secondary disabilities that we were just talking about? Job or financial loss, relationship or social loss, lack of social support or a sense of isolation, barriers to accessing medical and psychiatric care. So when you're looking at the risk factors, typically you're looking at a couple risk factors that might tend to suggest that someone might be at risk for suicide. And what this kind of highlights is that actually folks with fetal alcohol spectrum disorders actually have a higher set of risk factors that leave them at a greater danger for committing suicide or causing great harm to themselves or folks around. Okay. So slide 12. So I pulled, these are the risk factors on slide 12, kind of all off the Surgeon General's report. And they're broken, I haven't broken down between shared risk factors, so these are the ones that definitely got identified as being common. And then there's this other list that I'm calling case-dependent risk factors. So taking a step further, these are all symptoms and risk factors that could be present, but you really have to take it on an individual basis. Okay, so hopelessness, that's a sign, and that's a risk factor for suicide. Well, just because someone has a brain-based disorder doesn't mean that they can't also feel hopeless. But yet not everybody does. Some physical illnesses, previous suicide attempts, family history of suicide, easy access to lethal means. This is a big one in Alaska compared to other places. Now, why is this a big one in Alaska? Anyone? Hunting. We have a lot of guns here. Yeah. Any other? Yeah. Yep. I mean, hunting and guns is the access to weapons are fairly, a lot of knives, a lot of drugs are easily accessible. Local clusters of suicide that have kind of a contagion influence. You hear a lot about that in the media sometimes. Or that when there's several incidences of suicide, they tend to be influential on or significant people to the community or to the individuals that leads them to be at greater risk. Sometimes there's some stigma associated with seeking help and help-seeking behavior. You know, I don't want to be seen as crazy, so I'm not going to go talk to the village health aide. I don't want to get singled out because I have a mental health problem. There's also some cultural and religious beliefs that can also affect, and that's one that we tend to overlook sometimes, is that culture and spirituality and religiosity actually really play a big part of people's lives, and so again, some case dependent factors. So it may vary. Not everybody's going to have it. Okay, so what does the empirical literature tell us about fetal alcohol spectrum disorders and suicide? When you look at the literature, well, when I first started looking at this, there was really no hard data. There really wasn't any hard data. That big secondary disability study, Streissguth, was really the only one that actually talked about suicide. And I'll talk a little bit more about that here in a little bit. But it was kind of just one part of this great, huge study. And so they didn't really focus a lot on it. But now over time, there's been a little bit more done on it. Not a lot. But when you look at it, there tend to be two types of studies. There tend to be clinical studies, or kind of this retrospective study where we know these people are all affected by fetal alcohol syndrome or fetal alcohol spectrum disorders, and then we're going to look back and see what they've experienced. And these types of studies have some different issues, but there's just not a lot out there. Slide 14, this is a table that a colleague and I had in a presentation we did on suicide and FAS in Canada. And this actually comes out of that big study done out of the University of Washington. And the history of suicide threats and attempts was based on caregiver report, and that's an important phrase there. We found that that in terms of threats, kind of a history of threats. Again, this is a lifetime history, so it could have happened at any point in time over the course of their study. And as high as about 41% the folks in the age range of 21 to 51 had threatened suicide at some point in that study. 18-19% in the age range of 6 to 11 had threatened at some point, and so on. And then actual attempts, the numbers kind of dropped down a little bit more. Again, it's about 22-24% of the adults, 21 to 51, had actually attempted over the course of their lifespan. So that's like, okay, well, that's starting to give us a little bit more, but what else has been done? Actually, jumping back, one of the Lemoyne, who's the French pediatrician, he actually followed up his original group of folks that he was working with, and 7 out of 77, or about 9% of the adults now, had attempted suicide with fetal alcohol. Kind of on the continuum, had committed some attempted suicide. And there was reference to the number that had succeeded, but it wasn't listed, and so I'm still kind of digging into that a little bit. Kind of based on this, I thought, okay, I decided to do a study because there just really wasn't much out there. And I mean, there's the Seattle stuff, and then there's this thing over in so when I was at the clinic and running the clinic, I looked at our clinic records and kind of our charts, and I compared them to the emergency room psychiatric emergency response records, and basically looked at their logs and compared to see, all right, which of my folks that we've worked with have been seeing by the emergency room staff, the behavioral health urgent response group team. And what I found was that out of all the people that had been referred to us for an assessment, out of about 451, about 2.2%, so about 10 people had been seen by the emergency room folks for a self-harm assessment or for a suicide attempt. So when I was looking at and comparing the databases between the folks that I had evaluated and not, we actually got down to it, and suicide as a suicide attempt doesn't tend to happen usually under adolescence. So if you look at the age range that it's usually kind of focused on, it's kind of that 13, that teenage, the 13 to 18. When I looked at just those age ranges, it actually jumped up to about 5.8% of the folks that we had evaluated had been seen and evaluated and assessed for self-harm or suicide attempt or ideation. Another kind of related to part of that University of Washington thing, this is stuff that had kind of started to come up. 72%, and it was a small sample, they only had 11 in their sample, but a big chunk of that reported suicidal ideation at some point in their lifetime. 5 of those 11 described their thoughts as serious suicide ideation. Out of that 11, over half had one suicide attempts. Again, this is kind of over this drop 415. So trying to take a little bit more of a scientific, empirical kind of approach. 5 of the 6 attempts that they found were moderate or severe, and even more importantly, in all the cases of the attempts, the first attempt was never responded to by medical professionals or psychological or mental health folks. So something's happening, and again, these are kind of coming from also caregiver reports. Some of the, so we're actually, the other studies have been done by a lot of the caregiver reports. This is actually starting to look at and interview people themselves who are affected by prenatal alcohol exposure. So you're starting to get an actual picture of things that are going on. The fact that so many attempts were not responded to, that's pretty scary. And I think that's another, just some more recent stuff that I've actually came across. Again, small numbers, but they're starting to look at it. 2 psychologists out of Alberta were looking at mental health issues in one of their community-based programs, and they did a chart review. And out of the 100 or so some odd people that were in their program, 24 of them were easily identifiable as having a fetal alcohol spectrum disorder or suspected fetal alcohol spectrum disorder. And out of that 24, 2 had made in their charts. 2 of them had some mention about suicide or self-harm. Again, these are people in a program that they weren't specifically asking about suicide, but it was or self-harm, but it was raised to a level that the clinician was able to identify it, or that the client reported. But again, that's still high. And then one that I actually just kind of came across about a week ago was there's this great study done in Canada where they're looking at the economic impact of children in care in the Canadian system, in foster care, and they looked at, they had approximately 600 kids with a fetal alcohol syndrome diagnosis or suspected of. They had a control group of, again, air quotes here, of the general normal population, so kids who had not been exposed and weren't diagnosed, but they weren't in care, so they weren't in foster care. They had 5,000 matched for age and something like that. And when they looked at it, the rates, again, population rates, for the kids with fetal alcohol spectrum disorders, it was a rate of about 16.58 per thousand, and versus the general population with no alcohol was about 1.8. Of the group with FASD, I thought it was interesting. It was there were 600 kids. 10 of them made 11 attempts, and so that's out of 600. Okay, 10 out of 600 made 12 attempts. When they looked at the general population, 9 children out of 5,000 made attempts, 11 attempts. So kind of a different scale, but it kind of starts. It's probably one of the bigger studies out there. Again, this wasn't the main focus of the study, but this was just kind of one of the parts because it led to hospitalization in these cases. So and then kind of one out there that this is because I don't own it, the data, but the person I co-presented with, we reported this, and she did some data mining, and this is out of the Seattle database, and where they're following kind of over the 40 years, and they found that when she looked at folks with high alcohol exposure compared to folks that exposure, that the ones that the 202 with high alcohol exposure, about 24 or almost 12% had one suicide attempt, so with high levels of exposure. At low levels of exposure, kind of a similar size group, about 4% had reported. So it's starting, I mean, there's starting to be more numbers. It's kind of giving a picture that there are folks with brain-based disorders. Now you might wonder, okay, well, so I walked out of the zone here. How does this compare to other brain-based disorders or other folks who might have brain-based disorders? And this next slide came out of it's kind of a conglomerate of some information, but Janet, my colleague, looked at the literature and kind of what we just talked about with the FAS, but looked at intellectual disability and rates of suicide, and to kind of compare. And so she's kind of comparing the Seattle data to some information on intellectual disabilities that's in the literature. And the Seattle data had about kind of 22 to 24% of the folks had reported some suicide attempts. Within the literature that she looked at on intellectual disabilities, and this is kind of the new term for individuals would have been considered in brain with the term mental retardation or borderline intellectual functioning. About 10% had some suicide attempts, which is both greater than the U.S. average. And just for comparison, kind of the inpatient psychiatric literature. So again, kind of giving you the scope that shows that folks with brain-based disorders are at greater risk, and they're starting, and it's being seen more and more. Now, this is all a new field study, so folks are starting to dig into it. One of the earlier questions was, gestures versus actual, or methodology, lethal means versus not. So, there are folks that have started to look at that, and I think we'll see some interesting stuff. Now, when we talk about suicide, and I think we kind of touched on this earlier, we all pretty much assume that, well, someone's depressed, and which kind of ends up leading into feeling suicidal and making an attempt. And we've talked a little bit about this brain-based problems that end up leading towards poor judgment and so on. But in terms of an area, there's really no specific model that shows what the specific pathways are for someone with fetal alcohol syndrome or fetal alcohol spectrum disorders to end up attempting suicide or not. One of the things that kind of over the course of time that I started, you might need to make sense out of what I was seeing, is I started to look at kind of over time the folks that I was working with that had prenatal alcohol exposure or who were diagnosed with kind of fell on the spectrum. The ones that I was working with, the folks that I've been working with, they tended to fall into kind of 7 categories, and each one of these categories is kind of really different. And kind of in the course of my clinical work and in talking and consulting with others, the way the presentation tends to arise, I've got them kind of broken down by whether someone was suicidal or not. So like my first category here is not suicidal but reports suicidality. So one of the pictures that we see is that sometimes we're working where there's an individual that has poor communication, poor skills, they use the wrong words, they're not really suicidal, but they end up saying something suicidal. And we are now so sensitized to the issue of suicide that it trips the alerts, and everybody goes into mode, kind of into the saving mode. The person may know what the words mean. This is one of the, when we go back to the learning and the cognition and so on, they may know the words in speech and language issues. They may know what, I'm going to kill myself. I mean, they know the word, but do they really know what it means? It's like, I wish I was dead. Well, do they really know what dead means? Another category here is not suicidal but has risky behavior. This is where someone does something risky without really the understanding that there are some significant consequences to this. Kind of a thrill-seeking kind of behavior, maybe. You look at someone and say, that guy's nuts for skiing down that, or for jumping between, But because of the brain-based damage, their ability to say, okay, if I jump between this table and that table and miss, that I may hurt myself, it may not be there. So they may not appreciate that there may be some dire consequences to that potential thing. When I was growing up, not to make light of brain-based disorders, but some say adolescence in general is kind of a brain-based disorder. But some of the kids that I was in high school with were engaged in car surfing. And I don't know if you know what car surfing is, but it's basically getting out of the vehicle, of a moving vehicle, and riding on the hood, standing on the hood or the cab while it's moving. Kind of looks cool, sort of, maybe, to some. But what happens? We find that those who engage in that behavior tend to get injured and tend to get hit by cars and run over by cars and so on. Well, yeah, it's risky behavior that some people may perceive as suicidal when they're not perceiving that what they're doing is dangerous or so on. Jumping off of things. Worked with a lot of kids who like to jump. Stairs are wonderful. It's like, can you jump down the 12 steps from the one landing to the ground? It's just fun. Not suicidal, but gets hurt or injured is another one that I've seen. Compromise, they don't perceive pain, and kind of a little bit of what we were talking about there. I worked with a kiddo one time who just, in terms of just for pain, kind of a pain tolerance, dislocated his big toe while barefoot in a gym, and somehow later got the sock on, the shoe back on, and it was 3 days before the pain. It didn't hurt. You just know that the toe was at a funny thing, and his sock and shoe didn't fit quite as well. It took 3 days for the pain threshold to hit a point where it hurt, kind of thing. This is this is the compromised nervous system in our pain threshold. So we have gets hurt or injured. So they may have done something that has led to an injury, and they haven't responded to it in a way that should have been taken care of. Well, sometimes this gets perceived by others as being a self-harm gesture or a suicidal intent. When they weren't actually suicidal. They got injured but didn't have the ability to recognize it, that it was a life-threatening issue, or seek help. Another category, and this is one that will drive a clinician batty, and has driven me batty at times, and this is the person who is actually suicidal right now. And when you set off the alarm, get that person to to work with the emergency room folks in 10 minutes, they are no longer suicidal. They have moved onward. One of the kiddos that you consulted with in a program was suicidal. Got him to the emergency room, and the clinician looking at him said, "Why are you here?" It's like, "I have a toothache." "Okay, see you later. Thanks for wasting my time." It was basically what the clinician told the staff that brought the kid to the next day, back in the emergency room, once again. But and this was an issue of shifting attention and memory, and the memory was affected enough that anyway. But it happens. Another category is suicidal, but denies or doesn't understand it. So they do feel suicidal. And when asked, they deny it because they don't understand the language that you're using. So another kind of category. And then kind of the last category is there's suicidal. They admit it. They attempt it. And so 7 different ways that over time that I've seen and working with others that folks with exposure have kind of manifested or been seen. Since we're kind of shifting into some clinical presentation, I have a case study for you. Here, this is just to kind of talk a little bit and put it into actual. We had a 15-year-old girl who had a history of depression, of ADHD. She was prenatally exposed to cocaine. She was admitted to the emergency room for threatening to overdose on her medications. They happen to be psychiatric medications. So the clinician got her to the emergency room, and they requested an assessment to see, basically they wanted to figure out, is it safe to let this girl go home, or do we need to think about hospitalization or some higher level of intervention to keep her safe? So if you think about those different groups, keep in mind these different groups as we go through this. Okay, so presenting at the ER for an assessment. So they got the behavioral health, the psychiatric team in there and checked she told the therapist she was confused, didn't know what to do, and she wanted to die. But a couple hours later, by the time they got her into the emergency room, she denied wanting to die. And so that starts to kind of give a little bit of a picture. When you looked at her history, she'd been in treatment for about 5 years since she was 10. She's been on a range of medications and has complied with them sporadically for ADHD and depression. She recently just restarted her meds. She hadn't had any previous attempts, but had a couple episodes of thinking about suicide. She had family history of suicide attempts and mental health and substance abuse problems. And importantly, she evidenced thinking of future thinking. She wanted to go to college. Okay, when we're thinking about what I was just talking about in terms of different, where does she tend to fall in those categories? Kind of suicidal at the moment, but she's kind of shifted out of that kind of mode. So the psychiatric team, emergency team, in terms of their outcome, their evaluation outcome, the consultant concluded that she was past her initial desire to kill herself, or to be dead, and it wasn't really clear if she really wanted to die or not. So some challenges there. But the bottom line was she didn't qualify for hospitalization. There was no way that they could put her into the hospital. So what did they do? They contracted for safety. So they did a safety contract with her, to not kill herself or make an attempt. And the parent agreed to provide supervision until the following day when there was a follow-up appointment scheduled back with the crisis team. Again, we had somebody into the emergency room. We want to check on them. We don't want to let them completely go yet. So as it happens, about 3 months later, we saw her in the diagnostic clinic. And when we saw her at the diagnostic clinic, we didn't know that she had this. This episode had not risen. The parents didn't tell us. She didn't tell us until a little bit later on in the process. In terms of the diagnostic, our clinic uses the University of Washington's diagnostic system. It tends to look at 4 areas: growth, progress. We didn't find any history of growth deficiency. We looked at the facial characteristics. She didn't have the facial characteristics that were consistent with fetal alcohol syndrome. So physically, she's not demonstrating any kind of sign. So you look at her, you don't think she's got fetal alcohol syndrome or there's something wrong going on. She looked, and this is air quotes, normal. But we start to get, a big part of the evaluation assessment is we get into the central nervous system. There had been no brain imaging, normal head circumference, there was no specific neurological impairment. It's like, okay, so we dig further. So as we get into the assessment, you look at all those different domains, all those primary areas, cognition. What we found was her IQ score was in a low average range with a wide variation of performance. So when you're doing IQ assessments and looking at cognitive assessments, there's a bunch of different individual skills that you're looking at, and her performance was kind of all over and scattered, so no consistent performance. But when you averaged them all out, kind of came into that low average range. When you looked at the deficits in executive functioning and visual perception, there were pretty significant problems going on there. Auditory processing and memory and learning. And what's auditory processing? That's what you're hearing. That's your expressive, your ability to understand, communicate, but also to take language in and understand it. Definite problems in memory and learning. Okay, we found speech and again, kind of the receptive language, phonemic awareness, understanding language and language processing. We found that she was in the 11th grade, so she's in high school, a year away from graduating, but her academic skills were at a 3rd grade level, and her reading skills were at a 3rd and 4th grade level. So in terms of a diagnosis, this is not going to mean a lot, but basically it's not fetal alcohol syndrome, but it's an alcohol-related thing, alcohol-related neurodevelopmental disorder. Pretty significant problems, but it just didn't have the physical manifestations, outward physical. So keep this in mind. This is all very important stuff. Why is all this important? So why would this pattern of things be a problem when you're thinking about working with someone who may be suicidal or trying to figure out if someone's suicidal? You've got you've got communication problems, as someone in the audience has said. Yeah, what else? Okay. So in conjunction with the communication, there's kind of the linkage with concrete and abstract thinking. I mean, do they really understand kind of this higher? I mean, our whole world is set up to be abstract, you know. I mean, it really is. And can they understand? Can they make that connection? Yeah. Yeah. There's hopelessness. There's kind of this general pattern of problems that would make someone have difficulty understanding someone who's asking them about suicide. Mm-hmm. Yeah, this person was in the right here, right now, and not kind of getting absolutely. So one of the things that's pretty common practice when someone's suicidal is you do a safety contract. So does anyone, given kind of how this is looking, and we found in the clinic, how do you think that a safety contract would do? Right, absolutely, absolutely. You want us a backup plan. Yeah, I mean, there's language problems. Do they understand what I mean? And I'll talk about safety contract here in just a second. But can they comprehend it? So FASD characteristics and assessment, why worry? Well, this is all what we're just saying here. We've got a lack of understanding of consequences. Cause and effect, inability to process abstractly, all things that we were just talking about, may not understand lethality or finality of actions, executive functioning problems, that's, you know, have problems with starting and stopping behaviors. You know, if they start something, can they stop it? May perseverate. I mean, this is kind of, you get stuck on something and you stick with it over and over and over. May perseverate on self-harm thoughts or behaviors, have a difficulty starting or stopping. Language ability, may not be able to communicate accurately their emotional state. One of the things we find with individuals that with prenatal alcohol exposure is that they experience something called alexithymia, which is the inability to recognize emotional states. So what would be on my face if I was happy? Smile. Hopefully not a scary smile. If I'm mad, what does my face look like? Should look like a kind of thing. Well, there's an inability for some folks to recognize those mood states in others and in themselves. So that could be an issue. Then we've got kind of just an impulsivity that in the here and the now, and maybe shift attention or memory. They may report different things to different people, and some people may think they're lying, but they're actually being truthful. So when you're doing assessment or when you're faced with this, you do your standard stuff. You do your standard protocols. It'd be slide 29. You do standard protocols because that's the standard of care for assessing and working with folks. If you think suicide's an issue. You want, as you're doing that though, you also want to be careful of and avoid diagnostic overshadowing. Now, diagnostic overshadowing is underestimating a psychiatric or a mental health disturbance in someone with a developmental disability because of their cognitive deficits or their problems. So basically, you're seeing something, but you say, well, that's really not an issue because that's really part of their fetal alcohol syndrome. So, the labile up and down mood, like, well, people with fetal alcohol syndrome, they tend to be up and down in their mood, or they tend to be really impulsive. Not everybody is impulsive, but the diagnostic overshadow, it's about disabilities because you end up missing some really key symptoms. Difficult it's difficult with people with fetal alcohol spectrum disorder because most don't have an intellectual disability. Most function kind of in that low average range of functioning. One of the myths out there is folks with fetal alcohol syndrome or fetal alcohol spectrum disorder are mentally retarded, and that's not the case. Low average intellectual abilities and neuropsychological deficits compromise the function. So kind of the whole package is getting in the way. So you really need to consider what's the impact of this neuropsych functioning and what the communication functioning is and how those two interact. I mean, in that case example we showed, there's some communication issues that can lead to some pretty significant problems. So what do? Well, like I said, you do standard practice. You always start from there, from that side. If someone you think is suicidal or is going to hurt themselves, you need to do what you do because that's the standard of care. You need to take all precautions. One of the things that you need to do as a part of that is you need to do a mental status exam. Now, as a clinician, and I'm going to tell on my peer clinicians, a lot of clinicians don't do mental status exams. And that's something that doesn't feel natural while you're doing a therapeutic interaction with somebody or you're doing an assessment, and so that gets overlooked. But doing a mental status exam is really important, especially when you're working with somebody with an intellectual disability. But in particular, for all the reasons that we've talked about, with someone with fetal alcohol spectrum disorder, because you need to get some sense of what their cognitive functioning is. And this is probably not everybody is going to be able to get to a diagnostic team and or a neuropsychologist and have a super duper evaluation that's going to give you this. But the mental status exam is something that you can do that will give you a snapshot of someone's functioning level. Is it perfect? No. But it starts something is going on. So do a mental status and look for signs of cognitive impairment. When you are working with someone and the assessment and intervention plan is coming up, you need to take cognitive impairment into account. You should probably take it into account even if someone doesn't have overt signs of cognitive impairment. Keep it simple and concrete. And I'll talk about that here in just a second here. And at some point, this process is all about determining risk, and so you have to make a judgment about that. At some point, this process is all about determining risk, and so you have to make a judgment about that. These are all key parts of a suicide risk assessment. You're looking at suicide status, thoughts, feelings, and talk. You're looking at gestures and attempts. As a clinician, you document all of this stuff when you do a suicide risk assessment. Gesture and attempts, histories, current, suicide plan, do they have access to means, do they have access to guns, medication, whatever. Is there a history of suicidality? What's their substance abuse? Precipitating factors, are they in psychological pain? Research is showing that mental health issues or not, people don't tend to commit suicide or attempt suicide unless they're in some sort of psychological pain. Have they experienced the loss? Are they isolated? Is there mental health, psychopathology? Here's a question that gets asked. One thing that would help me no longer be suicidal would be, that's a kind of a nice part of a typical suicide assessment. So how does the mental status exam fit in there? Well, a mental status exam goes after executive functioning. Some couple simple ways of getting at it. Ask them to do something that requires a couple steps. So could you pick up that piece of paper, put it under my foot? Okay, do they get, I mean, that takes a lot of, some understanding of, and planning and organizing and sequencing, some comprehension. Take a paper, fold it in half, write your name on it, give it back to me. I mean, steps, multiple steps. You can go after their judgment and insight. Look at that help you understand their judgment. Here's a real common question that looks at judgment. I have a new end time, 5 minutes later, 10 minutes later. Go away, go away. I'm gesturing at the screen for those who in other places. Okay. So what would you do if you were in smells? What would you if you smelled smoke? Okay, you're starting to look at, what kind of smoke. Okay, so you're starting to put in a little bit higher level of thinking process in here. Is this, you're making a judgment, and you're starting to say, is this heavy smoke? Is there flame? You're starting to, do I need to get up and run away? Or is it tobacco smoke or whatever? But would any of you just jump up and shout fire and run out of the room? Probably not. It's a judgment. That's a concrete and abstract kind of judgment. Okay. This is great. I'm just going to keep pushing the button. I keep getting time with these. It was good. I kept getting 5-minute increments. So go away. Okay. Okay. Totally. Language functioning. Real simple. Have the individual name objects. What is this? Cell phone. I mean, what is this? I mean, can they name some no ifs, ands, and buts? That's a pretty standard language functioning part of a thing. It starts to show understanding of language pieces. Mood, affect, and alexithymia. This is that word I was talking about with the mood and emotion. Show me what it looks like when you're happy maps. Happy, sad are kind of like the 3 core ones that everything kind of comes off of. Can they show you that? Attention and concentration. Can you spell world backwards? Okay, how about audience participation time? Someone do it. Without looking at the screen. Yeah, I know. I thought all the eyes went, okay, I'm going to read that. Another one is called serial sevens. It's basically you have someone count backwards from 100 by sevens. 100, 93, 86. So I'm going to cut you all some slack because of our time. We'll recognize that it's 9 o'clock on a Thursday night. And so there's all a certain level of cognitive impairment at this time of night. Memory. That's actually a point that is that if you ask someone to do this, you need to make sure you can do it yourself. So anyway, and memory, short term, longer term. I mean, you can. What did you have for breakfast? What did you do yesterday? So you can check into them. Sometimes you have. Here's a little bit more complex test. Is you have them draw these shapes, and the interlocking shapes. And so this task actually pulls on some pretty heavy stuff. And I'm hearing people say, I can't do that, but that's okay. But they have to recognize that these are 2 same objects. They have to recognize that it's whatever the word is for 6-sided, 2, 4, 6, hexagon. 2 hexagons. They have to be able to recognize where they intersect. They're not actually side by side. One's at a slight angle. And so when you're looking at this, you look at how they reproduce it. Are the lines straight? Are they squiggly? Are they? So you start to get some more evidence here. This is an executive functioning task too. So taking cognitive impairment into account means carefully assessing their understanding of meaning. If at all possible, get a family or caregiver to get some collateral input. Most folks who are severely impaired don't or crisis situation without some sort of caregiver for the most part. But if you start to suspect that there's something cognitive going on, see if you can find someone, a friend, a family member, or some sort of person who knows how to provide some backup. Using simple and concrete language is real hard to do sometimes because we're just also used to being communicating in ways that are abstract. Use multimodal communication, so verbally, physically, demonstrating pictures, having several different ways. Give them something in writing. Write things down. Write things down. Write things down. If you're working with someone who has brain-based disorder, write things down. I can't tell you the number of times that somebody would show up in my office because their social worker or their teacher or some told that, see Mike. Okay, see Mike about what? Okay, so write things down and give simple instructions, simple step instructions. So in terms of suicide, if there's something that you want from somebody, you want them to do, write it down. Checking for understanding a meaning. This is really important. I've kind of talked about this a little bit. This is trying to figure out what does death, dying, or dead mean. Do they really understand that? What does I wish I weren't here? Is that something you've heard before? What does that really mean? Well, that really means that I don't want to be here having this adult nag me to death. Just use the word death. I would rather be playing Xbox. I would rather be, whatever. So do you ever feel like hurting yourself mean? That's a question that many clinicians that are helping ask. But what does that really mean? That's very abstract. What does lethality mean to an individual? So trying to explore, okay, well, if you take these pills, what does that really mean? So you're looking at what are the consequences? Guns, and so do they understand what the consequences of using or attempting something is? What does "do you have a plan" really mean? I know people have asked that. I've asked that before I kind of clued in. It's like, do you have a plan to hurt yourself? Do you have a plan to kill you? So you have to figure out as best you can what these means. If you don't know what they mean, you can ask them. I'm not sure I understand you. Could you explain that to me? You're pulling them, for a consummate concrete, having them demonstrate something for you. Not the act of killing themselves, but you're trying to basically take something abstract into something concrete. Understanding meaning. Here's one when we were assessing depression, and it's like, on a scale of 1 to 10, how depressed are you? Well, what does 1 to 10 mean? Well, you have to give them the anchors, and 10 means a lot. We use it for depression, suicide, angry, whatever. So we give the scale. Well, we need to give them some sense of what this scale means. Because of the abstract, the large versus small numbers, you make it concrete, you can do some small, medium, large. On a scale of, it's like, how bad do you feel? Well, you're making it concrete. A little bit about family and caregiver input. The more accurate history you get, the better your decision or the better chance you'll be able to do something that's going to be helpful. Someone may not always have a diagnosis, but you can get a picture from all those things that we've talked about. There are people in this person's environment that know and can provide information. So sometimes it takes digging in to get it. To better understand their picture, because of language problems, this is where you have to rely on other folks sometimes. Sometimes people are eager to please. You can ask a question and they're going to try and tell you what you want to hear. And you can accidentally lead them directions that are wrong. They may want you up, so they read to something, make you go away. And like I said, they may have misunderstood the question. They don't want to seem stupid, so they give you wrong information. Any follow-up intervention and planning and follow-through, you need to have caregiver input. You need to have a collateral source a lot of times. So, hospital. So you have to make decisions. Do we let somebody go? Don't do safety contracts. Use a crisis response plan. Case management, care coordination is another intervention. Provide supports. Be an external brain and help. You're never going to be positive in most cases whether or not they for sure have a diagnosis. But you're going to have to make the best decision possible. And it comes down to doing something versus not doing something. Do you hospitalize them or not? And you're going to have to make a decision. And it's going to be hard. And can you keep them safe? It comes down to that. Can you keep them safe? Can you provide the level of supervision in their environment to keep them in the community? Or do you need a higher level of care? Can the access to means be eliminated or reduced? If there's pills in the house, can you control that? If there's guns in the house, can you control that? Whatever the acts means are, can you control that? What supports are available? I mean, do they have people who can care for them or provide the supervision support? Whether you hospitalize or not, write everything down. I mean, document stuff. Document. So if you find out someone has prenatal alcohol exposure, if you're a clinician, write it down. If someone, if you need to give someone a list of medication, or someone gives you a list of medications, write it down. If they're a poor historian and they can't report it on their own accurately, you'll have it documented. And the big one is if you think they're cognitively impaired, write it in the record. It can be cleared up. It can be assessed further. But right now, do it. Get releases of information. That's important for follow-up. Even if they deny suicidal ideation, follow up with them and the caregiver just to make sure. Because of a variety of instances, so you can have confidence in your decision. Now, talking about suicide contracts get used. They're typically a feel-good intervention for the clinician. What they're finding, there's nothing that is binding about these. I remember working in a residential home one time, and I followed policy, and I contracted for safety with a kiddo, and she was not affected, but her response to me was the finger. Said, "I'm going to hang myself at the drapes and the curtain." So yeah, I'll sign. You bet. So it's more to make us feel good. So and it's starting to be more the standard of care to not do safety contracts like that. Is the language understandable? We talked about that, and most of these are too abstract. Do they have the reading level to understand it? Problem, maybe not. Suicide contracts are abstract. Bottom line. So don't do them. Well, and people do them, and they continue to do them. But there's not much. Okay, I will end in 5 minutes or less. But there is not. I mean, there's no research that shows they're effective. But people will continue to do them because they think it's something that they can do. So, crisis response plan. Be clear about what the legal requirements are. Make sure it's collaborative. Involve as many people as you can in it. Identify alternative coping strategies, a crisis card, a prevention toolkit, behavioral activation. I mean, basically trying to figure out some other strategies other than the issue of harming themselves. Strengthen reasons for living. If you decide that someone is in fact suicidal, try and this is part of a normal suicide intervention, but it's especially important. Strengthen the reasons for living. Provide those resiliency factors. If there are specific times, phone numbers, and contingencies. So if this happens, call this number. If I am feeling this way, call Mike at. So call the police at. Be real specific. Write it down, and put it. If you're in a clinic or if you're in a program, write it down so other people can know it. I included this as just an example of a crisis card. When I'm feeling lonely and sad, I pictures. That was an intervention for somebody. That was something that made them feel connected and not isolated because they were pictures of their family and friends. I will call or go to a particular person or place. All right, if I call, this is the number. And you give this to them as a tool for them to carry with themselves in their pocket. I will call my counselor. If I feel like hurting, I'll go to the emergency room. I will call all possibilities. Prevention. Just practice it. Sort like the alcohol spectrum syndrome or spectrum disorders are at higher risk, just based on their judgment, their executive functioning. So we need to pay attention. We need to continue to do a standard look at risk factors, and we need to monitor closely. Monitoring and supervision tends to be a real main intervention. Strengthen the reasons for living. These are all things that you can do and that will help shore up resiliency. So, see, I know I can do it in 5 minutes or less. So, concluding thoughts. As professionals, I should have put caregivers on here. We can make a difference. It doesn't take much. For clinicians, it takes doing something differently. But our people who are working in programs, it takes doing something just a little bit differently, but it doesn't have to fix the scope. We have to be very conscientious about it, and we have to be thoughtful about it. But it doesn't take it doesn't take much to really make a difference, and a little bit can in fact save people's lives. And